Good evening, Mohan sir.
Hi,
Good evening, ma'am.
good evening. People have joined?
Sir, ma'am, Prabhat sir will join shortly.
Okay, we'll wait for him. Na? He's the first speaker, na?
Yes, ma'am.
All right, okay.
Good evening, Sabina ma'am.
Good evening, good evening.
फोन करेंगे तो आग लगी समझ रहे
Good evening, Prabhat sir.
Good evening.
Uma ma'am will start.
Hi, we'll start. Prabhat has joined. Thank you, Prabhat.
Yes, ma'am, we can start.
Okay, ma'am.
So,
Okay, sir.
good evening, everyone, and thank you for joining us on this discussion about breast cancer today. We know that breast cancer has come far in treatment. You know, it started with just mastectomy, then it was with axillary dissection, and then changes were made. You know, like breast conserving, sentinel node. So, a lot of things have happened in treatment in terms of therapy also. HER2 positive, hormone receptor positive. You know, there are patients who need more, and there are patients who need less. And optimizing treatment, sequencing treatment has become a very, very important part in how we treat breast cancer today. We know that even within breast cancer, there's a lot of heterogeneity, and that's what we will hope to address today. So, with that, I would like to welcome our first speaker, Dr. Prabhat Bhargava, and he's going to talk about de-escalation strategies in early breast cancer. So, over to you, Prabhat. Thank you for joining us.
Thank you, ma'am. I will share my screen. My screen is visible. So,
Yes, sir.
managing early breast cancer, focusing on de-escalation strategies in HER2 positive breast cancer is the topic that I will be talking upon. It is a heterogeneous disease, and one size, even if they are HER2 positive, maybe HER or one size doesn't fit all, is what we will discuss today. So, first thing is, how did trastuzumab come into picture? So in 1987, Dennis Salman first identified that HER2 amplification is a prognostic marker. And if it is a poor prognostic marker, then inhibiting HER2 may have some role, and that is when trastuzumab came into picture. And then first article on trastuzumab till now with the ADCs have begun with just based on this work, that trastuzumab came and FDA approved in 1998 for metastatic breast cancer based on this NEGM study, where a response rate to chemotherapy increased by adding trastuzumab to chemotherapy from 32% to 50%, and median time to progression increased from 4.6 to 7.4 months, and duration of response was 3 months. What's striking was OS increased by 5 months compared to progression-free survival of only 3 months. The OS increased 5 months. So there was long-lasting effect of the antibody going on in the body in spite of stopping trastuzumab. And then multiple trials have come in adjuvant setting and neoadjuvant settings, which have consistently shown that overall survival, disease-free survival and overall survival benefit is there up to the tune of 10 to 12% at all time points, starting with 3 years DFS in this first trial of 12%, which was maintained roughly 11-12% in terms of OS also at 10 years. So trastuzumab is an important part of the study, but what they did was they gave it for 1 year. So since then, multiple trials are going on. Whether more than 1 year is important or less than 1 year can be done. So I will move from this HERA trial where more than 1 year was tried, but it did not show improvement in survival benefit. And I will come to de-escalation strategies. That is, first is de-escalation in terms of trastuzumab. So moving to de-escalation of trastuzumab, first is FINHER trial. A Finnish group tried whether 12 months ke badle if we can give only for 9 weeks. And what you can see that relapse-free survival difference is roughly 11% is the ballpark figure that we saw with 1 year of trastuzumab also. So if we give only 9 weeks of trastuzumab, relapse-free survival improves by 11% from 78% to 89%. So trastuzumab is an important part. Multiple trials I skipped in between, which show that it is an important part. But even 9 weeks would suffice, is what we can gather if cross-trial comparison is done. So, but we have to keep in mind that this was not designed to compare 9 weeks versus 1 year. This was nothing versus 9 weeks, as we do in today's era for immunotherapy. No immunotherapy versus low-dose immunotherapy. And first randomized trial which demonstrated that even 9 weeks have benefit, and which is almost similar to what 12 months of trastuzumab gave. Based on this, there were multiple trials of 9 weeks versus 1 year or 6 months versus 1 year, but only Perspiron could show that it met its non-inferiority endpoint, and non-inferiority was reached, and confidence interval was also well within the hazard ratio, but others did not. Okay. So, why Perspiron succeeded and FAIR failed is because of similar efficacy estimate, that is hazard ratio of 1.01 or 1.08, is because of the non-inferiority margin of FAIR was only 1.15, but for Perspiron it was 1.32. So 32% risk was allowed in Perspiron, and that is why Perspiron succeeded. But later on, this random landmark JAMA network analysis published in JAMA by Dr. Seema Gulia and other meta-analysis is also there, which could finally said that cardiac toxicity also reduces, and shorter duration of roughly 6 months or plus 9 weeks during with chemotherapy is good enough for patients, selected patients. So yes, 9 months is also 6 months is also good enough compared to 1 year, but which patient is the question mark. So Perspiron long-term outcome do indicate that in Perspiron why it succeeded was of the fact that 59% was N0 and 69% was hormone positive. So majority of patients were early risk and good risk in terms of being hormone positive also. So in this cohort, maybe we can come down to just 6 months rather than continuing for 1 year of trastuzumab. And there may be still, may not be doing any inferior treatment for our patients. And so this is taking from de-escalation strategy in terms of basic trastuzumab. Now moving on to further de-escalation strategies. Now, I have skipped those trials where TCH-PH was also compared to AC-taxane and it was non-inferior. But now further studies have come, NeoCARB, where they have tried to omit that maybe carboplatin itself, which we use routinely in neoadjuvant setting, is not useful. So first trial is NeoCARB trial, where they plain omitted carboplatin in the experimental arm. So it was a phase 3 multicenter randomized non-inferiority trial of just 774 patients of both stage 2 and stage 3 HER2 positive breast cancer. They were either given 6 cycles of THP or 6 cycles of TCHP carboplatin, just with primary endpoint being PathCR And you can see that PathCR merely increases by 1% by addition, 1.8% by addition of carboplatin, and they could achieve the non-inferiority margin, what they have assumed. So serious effects with THP is only in 1.3% of patient, but with addition of carboplatin, 3% more serious effects are seen, and grade 3 events are increased by roughly 15% by addition of carboplatin. So NeoCarb study says that THP achieved non-inferior PathCR compared to Paclitacarbo and HP, Texan HP, Carbo and HP, and markedly lower hematological toxicities. We know carboplatin will cause marked thrombocytopenia and neutropenia, but consistent positive whether patients are uh, hormone positive or hormone negative, there was difference. Predominantly stage 2 population were there, and stabilize generalizability again to all patients remains uncertain. So maybe because in West most patients are in node negative, again here for node negative special we can omit carboplatin. Similarly for node negative we can shorten duration of trastuzumab to 6 months. Another good study, but this time from the East, phase 3 randomized multi-center randomized trial of again 689 patients. Both stage 2 and stage 3 HER2 positive early breast cancer were included. Again, they omitted carboplatin and changed taxanes to nab-paclitaxel. There weekly nab-paclitaxel. There was a philosophy why they specifically chose nab-paclitaxel over any plain taxel, and why they chose weekly. And they could show that with standard TCHP, the PathCR is 57% compared to nab-paclitaxel based HP, it is 66%. So it is not just a non-inferior, it turned out to be increased PathCR with this nab-pacli trastuzumab and omitting carboplatin. So superior PathCR was achieved with chemotherapy, which was planned for de-escalation. And greatest benefit was seen in patient with hormone negative disease. In hormone negative disease, the PathCR has been reported to the tune of 86%. So 86% can achieve PathCR just with nab-paclitaxel trastuzumab, and only 14% will go on to have high risk disease later on. So good regimen. But point to be noted here is more than 80% of patients will have more than equal to grade 2 peripheral neuropathy, and that may not be acceptable for every one of us. They have reported grade 3 as 13%, but in neuropathy, even grade 2 is very significant. And when combined with grade 2, grade 3 becomes more than 80%. So that is a point to be noted. But yes, very stark difference in PathCR of 86% in hormone negative breast cancer patient. Now coming on to adjuvant regimen. Adjuvant regimen, a single arm study could become so hit that it was a single arm multi-center phase 2 de-escalation trial of 106 patients of HER2 positive, which were included were of tumor size less than 3 centimeter, predominantly node negative, but 6 patients have micrometastasis. So again, in node negative patient, either you can give 6 months of trastuzumab, or you can use this regimen, which is commonly called as APT regimen or Tolani regimen, where patients were given weekly, again weekly paclitaxel plus trastuzumab for 12 weeks, followed by 1 year of trastuzumab. It had 67% of hormone positive, as hormone positive is predominant cohort. But the point to be noted here, they wanted to recruit less than 3 centimeter, but 80% of tumor were less than 2 centimeter of size, and predominantly were less than 50% were less than 1 centimeter of size. Node negative, as we saw above. So 3-year DFS, obviously, if we take such cohort where 50% of patients are less than 1 centimeter and node negative, 3-year disease-free survival is 98%. Only 2 distant recurrence had occurred by 3 years. Grade 3 neuropathy was 3.2%, and symptomatic cardiac failure was 0.5 percentage. At 10 years, they could show disease-free survival of 91.3%, 10-year recurrent-free survival of 96.3%, and 10-year OF was 94.3%. So this has become instant hit, and everybody has used in practice that we can come down on anthracycline and just weekly nab-paclitaxel trastuzumab for 12 weeks, followed by 1 year of trastuzumab suffices. Then an attempt was made to use TDM1, but the 5-year DFS did improve by giving adjuvant TDM1 in a similar cohort. They have specifically taken patients of less than 2 centimeter and N0 or N1 micro, They were given either 1 year of TDM1 or 12 weeks of paclitaxel followed by 1 year of trastuzumab. Again, primary object was this time was compared toxicity and not efficacy, because it is very difficult to prove a difference in efficacy at this level when we are playing above 95%. They could show that 5-year DFS was invasive disease-free survival was superior percentage-wise for TDM1. Recurrence-free survival was superior, but 5-year OS was almost the same. And that is why adjuvant TDM1 could not come into picture as adjuvant therapy, and still tolerated regimens remain standard of care in patients with less than 2 centimeter of T size and node negative or micro. So clinically relevant toxicities were similar, and they could not even show that it is more safe. There was almost similar toxicity in both the regimens. However, TH had more neuropathy, alopecia, and neutropenia as one would expect, and same with TDM1, one would expect transaminitis and thrombocytopenia. Same was there. So TDM1 is an alternative for selected patient where you want to avoid paclitaxel-induced neuropathy or alopecia is particularly important. So both have almost similar efficacy, and you can judiciously use one of them. Now coming on to another trial where patients were given neoadjuvant de-escalation, where patients were given no chemotherapy. So arm was HP alone or weekly pacli plus HP. A very novel concept that if patients are undergoing PAT-CR, but point to be noted in my first slide was trastuzumab alone causes hardly any response. So trastuzumab alone was never tried as NACT in a bigger trial, only when combination with pertuzumab has been tried. Here they wanted to de-escalate the chemotherapy component, and they wanted to see that at 3 weeks biopsy, they wanted to assess early response in terms of decrease in Ki67 and low residual tumor cellularity. So aim was to identify in whom we can omit chemotherapy. What they found, if you omit chemotherapy in such a good biology disease where patient has a small tumor, the rough PAT-CR with omitting chemotherapy was 34%, but with chemotherapy PAT-CR was up to the tune of 90%. Total PAT-CR YP-T0N0 even node negative was only in 1/4 patient with HP, while with paclitaxel added to HP, it was 78%. So what they assumed that weekly pacli is still a critical component to neoadjuvant therapy. Pacli, if above paclitaxel we give dual anti-HER2 therapy, it adds on, and pacli removes the backbone. Early biological non-responders strongly predict failure to achieve PAT-CR and may identify patients who need treatment escalation. And chemotherapy cannot be safely be omitted in all comers. But yes, in 1/4 of patients it can be omitted. So next came where patients again are phase 2 small study of randomized multicenter open label trial for gain in 356 patients of HER2 positive disease of patient with tumor size of more than 1.5 centimeter. They were either given 6 cycles of TCHP as is standard of care at that time, or in experimental group they were given HP with endocrine therapy, and they were assessing response whether we can identify those 1/4 patients who don't need chemotherapy. They assessed response by PET CT scan, and if PET CT scan they had response, they were continued at HP for 6 cycles. But those who did not have response, they were then given paclitaxel, paclicarbo both. After surgery, they wanted to see how many patients achieve PAT-CR and no chemotherapy was given, and residual disease had received TCHP. So you can see great 3-year IDFS of 96% if we can identify patients who are responding on PET. So PET responders roughly 80% were there, but PET responders were not there in 20%. And those who achieve PET response, only 30% could achieve PAT-CR. So PET is not an ideal criteria to identify who will achieve PAT-CR on pathological examination. So main conclusion is highlighted in yellow that early metabolic response alone is insufficient, and PAT-CR after surgery is required to safely omit chemotherapy. Okay, 3-year IDFS is selected cohort who did not receive chemotherapy or who received chemotherapy could be 94%. So you are not doing anything wrong if you start with HP in selected group of patients where you feel they are not fit for chemotherapy, and you monitor them and judiciously use TCHP either in adjuvant if no PAT-CR is achieved or based on initial response to therapy. Another interesting trial in de-escalation setting is TRAIN 3 trial, where patients were a multi-center phase 2 trial adaptive design of again stage 2, stage 3 early breast cancer patients were given neoadjuvant TCHP. And if breast MRI after every 3 cycles was done, and if MRI, because we saw that PAT is not that great. Now this time they used MRI, and if there was radiological CR, they proceed to surgery just after 3 cycles. And if there was residual disease, then they were completed up to 9 cycles of therapy was given. The primary endpoint was 3-year EFS. So MRI radiological CR after 3 was seen in 36% in patients who are hormone negative, while it was seen in 73% who are hormone negative. In hormone negative, the PATH-CR correlation was 87 to 89%. So at least MRI has more correlation that if MRI says radiological CR is there, it hardly says you can see only 36% it could identify. But if it says that radiological CR is then yes, roughly more than 85% chances that patient will be in pathological CR also. So MRI radiological CR predicting to PATH-CR in hormone positive was bad. Only 53% correlation was there. And grade 3-4 toxicities, if you depend on MRI, you will give up to 9 cycles, then obviously 81% had grade 3-4 toxicity. So this trial gave us an idea that if you want to choose in patients, maybe MRI is better than PET CT scan, but MRI is also still not reliable in hormone positive disease. Maybe in hormone negative disease, we can do response assessment with MRI after 3 cycles and see whom we can de-escalate. Now moving on to another ongoing trials in de-escalation setting, I will move fast in view of lack of time. So Compass HER2 PATH-CR trial is where stage 2 and stage 3 hormone positive early breast cancer will be taken either 4 cycles of THP and no Anthra and Carbo will be given. So only THP. As we know, Carbo is also useless and maybe Anthra is out. So primary endpoint is 3 years recurrence-free survival in patient achieving PATH-CR. So after 4 cycles, if patient has PATH-CR, they will not receive any chemotherapy further. But if they have residual disease, then they will be given either TDM1 or TDM1 plus tucatinib. And the abstract presented in 2026 shows that only 44% could achieve PATH-CR, but it was higher obviously in patients with ER negative and less in patients who are ER positive. D-Crescendo trial is another ongoing which preliminary results not yet available in HER2 positive early breast cancer, where again patients were given 4 cycles of THP, surgery followed by response assessment adjuvant therapy is being planned. If there is PATH-CR, then patient will only receive HP. If there is no, then 14 cycles of HP. If there is more residual disease, then even anthracycline will be given. So D-Crescendo will let us know whether PATH-CR can be omit anthracycline also. Then there is Eridin trial, again as a phase 2 trial of the patient will receive either 3 TCHP or 3 TDXD, and their pathological response will be assessed. In HER2 Enrich trial, they will based on the PAM50 score, they will be assigned either TCHP or TDXD. But if they are more ER dominant, then they will be given letrozole ribociclib with HP. And if they are basal like ER negative and they are radiological CR, then they will continue to de-escalate and dose escalation to EC. Again, PATH-CR is the primary endpoint, and if residual disease is there, then they will be escalated. Things to note is HER2 DX is a novel biomarker, and maybe that will also let us know whom are more likely to achieve PATH-CR, and accordingly we can modify our regimen. Till that time, we are aware that we give dual anti-HER2 to most of the patients, or if early operated, then de-escalate them to only THP or TDM1 as per toxicity profile. So I will rest here that maybe 1 year of trastuzumab still remains standard of care for everybody, but maybe 6 months can be in selected patient. Dual HER2 is preferred neoadjuvant for stage 2 HER2 positive, and residual disease should be escalated with adjuvant TDM1 or TDXD if feasible. And maybe future we will be able to identify whom we can de-escalate further. Thank you.
Thank you, Dr. Prabhat, for that wonderful talk on de-escalation strategies in HER2 positive breast cancer. So, any questions from the audience? Otherwise, I have a few questions. Okay. So,
So
really nicely put. Yeah, go ahead.
hello.
Yeah, go
Yes,
ahead.
ma'am. Sorry. So, Dr. Prabhat, sir, that was a wonderful presentation. Just one point that it struck me during the Train 3 study that you had shown. So, if someone is given three cycles of the neoadjuvant treatment, and that patient shows a good response on the MRI of the breast, and patient is taken up for surgery, and then you are maybe able to find some residual disease pathologically. So now this patient is suboptimally treated as per the guidelines. So would you escalate him to TDM1, or would you want to give him the benefit of doubt and say that she did not get the full 6 courses of TCHP, and therefore we just based on breast MRI we did the surgery. So this patient is suboptimally treated. So how would you decide the adjuvant treatment thereafter if the patient does not get pathological complete response?
Good question. This is hypothesis generating trial, first of all. But what would I do if I've used this trial is what I'm saying. Okay. So in TDM1 Catherine trial, 9 weeks of neoadjuvant therapy was compulsory. If after 9 weeks of neoadjuvant trastuzumab they did not achieve PathCR, then they were escalated to TDM1. So 3 cycles is equal to 9 weeks. So ideally escalating them to TDM1 is good enough. But yes, if you had good intention and you want to de-escalate it, and then you have a great gut feeling that I have de-escalated and the patient does not achieve PathCR, so maybe giving 3 more TCHP later on, and then trastuzumab may also be a good point. But if you are following Train 3 regimen, then better to escalate.
Yeah, because now we are on one hand talking about de-escalation, and on the other hand, now we have Destiny breast data where we are talking about adjuvant TDXD being better than TDM1. So this is kind of a opposite end of the spectrum, isn't it, sir?
You're also
One,
talking about neoadjuvant TDXD now. That is also coming up.
Yes, DB12. Yes, correct.
thank you.
Yes, Dr. Prabhat, sir, you were saying something.
No, I agree. There is both ways studies are ongoing, and we really need to identify that in colon we are able to identify that stage 3 4 Kpox are good enough. So here also in stage 2 maybe omitting chemo is good enough. So why to give everything to everybody here also? So trials like this are also required, and obviously pharma sponsored trial will continue to, in that way that more and more escalation is required. But 86% PathCR with TCHP with nab-paclitaxel to per 2 is also good enough. Why do you want TDXD in such setting?
So, sir, have you stopped using carboplatin now in stage 3 NACT for HER2-positive breast cancer? NACT, you're not using carbo now?
I give it judiciously. In stage 2, I have given THP now. In stage 3, I add anthracycline.
Anthracycline.
We are still with anthracycline. That has never been shown to be superior. TCHP is not superior anytime to ACTHP.
Yeah, but it was non-inferior, if I remember right.
It was not,
Yes.
but never shown superior.
As such, even the data for the neoadjuvant TCHP comes from the Trifina study, which was a phase 2 study, and we've been all using TCHP everywhere, left, right, and center. But I think it will still be a little while before we all of us are convinced that carboplatin is now out of our guidelines for NACP.
Yeah,
Maybe
and
stage
when we
2,
talk about
stage 2,
Trafina,
maybe,
Trafina gave up to 9. Trafina, I think one of the trial gave up to 9 cycles of paclicarbo HP. So that will be really be difficult for patients to take 9 cycles. Even 6 cycles, pacli patients cries with neuropathy.
Correct.
So I feel 4 cycles is still good enough, and not to escalate to 6 cycles. And when Destiny TDXD 11, when neoadjuvant TDXD was tried, they compared with AC. So world over, AC still remains and when we interact with multiple international faculty, they will before TDXD, they said AC is still standard of care in many countries. Okay. Where even access to pertuzumab was there, everything was there. And that is why when a trial is designed, they are not designed to Prabhat ko hi karna hai. They sponsor definitely speaks to multiple KOLs and then decides, acha, AC is still standard of care, and that is why they have used comparator arm is still AC.
One other important point I always wonder in my practice, many times if you look at the affinity at least in the adjuvant setting, pertuzumab didn't really benefit the node positive patients, right? But many times in neoadjuvant, even if even if it is a clinically node negative disease, because we don't know about the micromets, we end up giving neoadjuvant TCHP or a THP regimen. So, how do you de-escalate? Do you really de-escalate if there is a PAT CR, or even if there is a PAT CR, do you really de-escalate to single agent TRUST-II after that in the adjuvant setting, or would you still continue giving HP as? This has always been my confusion in main.
Ma'am, there is a retrospective analysis from our institute where most of our general patients can only take 9 months or 9 weeks or 12 weeks of 12 P plus H, and obviously could not afford maintenance trastuzumab. And private side patient could afford maintenance trastuzumab. So it was a non-biased retrospective analysis. And when we saw that patients who achieve PAT CR, continuing trastuzumab in such patients also have 4% benefit. This is our retrospective analysis. And similar
Trastuzumab or pertuzumab?
I am saying trastuzumab. हाँ, पर्टू का तो इतना एक्सपीरियंस हमें भी नहीं था. Now with biosimilar pertuzumab it is there, and similar study is there for pertuzumab that those who achieve PAT CR with dual anti-HER2 continuing dual versus single, again there is 4% benefit, 3 or 4% benefit. I may be mistaking on number, but yes, 3 or 4% benefit is there for either of them continuing in spite of PAT CR.
So it's becoming more and more complicated. I think I think biomarkers are something that we are looking at for actually de-escalating, escalating strategies. And secondly, because it's a very dynamic situation, so I don't know how much ctDNA is going to maybe will it clear the confusion or sort of create more confusion, because I'm sure it is going to come as a part of not maybe in next few years, but few years down the line, monitoring ctDNA as a response to neoadjuvant therapy, and maybe deciding whatever escalation, de-escalation based on that. So I'm not sure, but I'm sure as a monitoring it might come in the future. What are your thoughts on?
Agreed, ma'am. I said for colon cancer, now we can omit based on ctDNA. So ctDNA, more refined ctDNA will come in breast cancer also, and neoadjuvant setting also. That if they were baseline ctDNA positive and later on they became negative, so irrespective of PAT CR, don't give chemotherapy adjuvant.
Any more questions? Do we have our panelists and moderator online? I think Dr. Rajiv unfortunately is traveling, so he is not able to give his talk. So he just let us. He just told us like last night, so I think it's difficult to adjust. So if the panelists and the moderator are ready, we'll move on to the panel discussion. But thank you, Prabhat, and thank you, Sohail, also. Very interesting discussions and insights on this topic. Are they around? Hello?
Yes, ma'am.
They are there, the panelists. And,
all panelists
Yes,
are there. Dr. Satyajit Pawar sir joining shortly, ma'am.
Oh, that's fine. But Dr. Santosh, our moderator, is there, no?
Yes.
Yes. So without further ado, we'll go to the next conundrum, that is antibody drug conjugates in breast cancer. It will be a panel discussion moderated by Dr. Santosh Kumar Chellapuram. And we'll have our panelists. Dr. Satyajit will join in a while, but Dr. Savinay, Dr. Shruti Goel, Dr. Nihanti Srinath, Dr. Sindhu, Dr. Suhail Qureshi, and Dr. Lal Mohan Soy. So over to you, Dr. Santosh.
Thank you, madam. I am audible, right? Hello?
Yes, you are audible.
Yes. Good evening, everyone. I think I would share my slides. I'm not allowed to. I request the organizers to allow me share my screen. So host isn't allowing multiple presenters.
Okay.
Yeah. So today we would be discussing how do we manage with the new emerging data. Although the topic I'm discussing among the molecules available, one molecule we have in India, other two molecules we do not have in India. We might get very soon access to other molecules.
I can't see the
That-
slides. Are you sharing them? Sorry.
Madam, I am not allowed to share the slide.
Can you
actually. I
can
think
you
the
allow him to
I need
please?
help.
Yeah. Can you please allow him to share? Can you
Yes,
allow?
ma'am, sure.
Yeah. Okay.
I think somebody should unshare the ongoing slide only later.
I think that's Prabhat. Dr. Prabhat, if you're around, can you please?
Yes, now I'll share. So, is my screen visible?
Yeah, I think you've started screen sharing. It will come.
Yes.
Yeah,
yes.
we can see.
Okay, so I'll start my presentation. So basically, ADCs, as we know, are a very interesting class of molecule. So I would ask my panelists if they have seen this movie, any relation to the topic we have discussed. Dr. Satyajit is around. Dr. Sanvijay.
Yes, sir, I am here.
Dr.
No idea
Shruti.
about the movie.
I think you are referring to this movie,
Anyone?
which is Troy. The Troy, right?
Troy was a very old movie,
I
sir.
think this
Anything
is
recently
only the
released?
new one.
The
This
movie
year.
about the Trojan horse. The Trojan horse.
Trojan horse. Okay, so this is the DC movie, The Great Trojan Horse. So basically, I view our drug like antibody drug conjugate as a Trojan horse drug, where it stealthily enters inside the cancer cell and it releases the payload there. So this is how our field of have been moved from native antibody drugs to antibody drug conjugates, which we have intervened. We also view this antibody conjugates in a different angle. So there would be very little tumor microenvironment whenever we discuss about our cancers, especially breast cancer, TNBCs or anything. So I view that as a B2 spirit bomber, where it do not explode immediately, it goes inside and then explodes. This is what we called as the bystander effect, where we want to kill the cells that are not expanding also, so that the main drug goes inside. So with this premise, we have a evolution of antibody drug conjugates in the field of breast oncology, starting with the TDM1, we have TDXT, we have the sacituzumab govitecan, we have datopotamab deruxtecan. So these are fast moving. So among these four molecules, whenever we choose a molecule, possibly depends on the side effects it has in the form of ILDs, the neutropenias, the stomatitis abnormality, and the ocular abnormality. So will this decide how do we choose our decision where multiple options are available? These are the few options that are in the horizon, targeting HER3, LIV1, B7H4. These are the molecules. So in this thing, I would ask the panelists so that understand this complex area where how do we sequence when two drugs are available or indicated in the same thing, how do we decide? And are there any real-term biomarkers? And how do we do the health economy, especially in Indian scenario? With this premise, I will start with the first case. 54-year-old lady, de novo HER2 3+ positive disease, but ER negative. She has metastasis to the liver and the bone, ECOG PS1, treatment naive for what do we say, metastatic disease. She completed adjuvant trastuzumab 3 years back. So after 3 years of adjuvant trastuzumab, she relapsed now. Biopsy we have done. It is HER2 3+. In this scenario, we have very good data that is coming. So how do we decide the first line? Do we go the Cleopatra way or do we do the current way? I would start with Dr. Satyajit. Dr. Satyajit has joined. I would ask Dr. Sanvijay. So how do we view this option of how do we decide in a HER2 positive lady who relapsed after 3 years with HER2 3+ status? So how do we go, Cleopatra way or the breast way? Dr. Sanvijay.
Good evening, sir. For now, sir, I will choose Cleopatra regimen for this lady. And after 4 to 8 cycles of taxane with dual anti-HER2 agent, I would probably think for adding tucatinib along with the dual anti-HER2 agent. So right now, sir,
Madam,
after
the
3 years, she is
patient,
relapsing. Cleopatra.
okay. The patient has no dearths of fund, and she comes forward with the data showing that Destiny is there. Why aren't you offering Destiny? Sir, Madam, Cleopatra is the standard yesteryears. So the reason for choosing Cleopatra over Destiny in this case, what are your viewpoints on that?
Sir, first of all, even if she is affording, sir, sir, if I would have given TDXD in upfront setting, sir, then if patient progresses on TDXD, how to sequence the further lines of therapy, that is a question. Secondly, sir, if this lady would have had brain metastasis, then I would have still thought to add TDXD with pertuzumab. And thirdly, sir, regarding this trial, TDXD pertuzumab DB09, they did stratification based on the PIK3 status also. So so it has been mentioned at n number of places that if the patient are having PIK3CA mutation, they don't generally respond well to trastuzumab, pertuzumab, and for them might be TDXD is a better drug. So all these factors would have helped me to choose the other regimen upfront. Till now, sir, I do practice Cleopatra first only.
Okay. So you would go with Cleopatra, but you want the information of PIK3 before quantifying further. That is what you do. Dr.
Yes, sir.
Shruti, so you have heard what Dr. Sanvijay has put forward her point of views. So which way you would go? So would you go the deruxtecan way, or would you do the other way? Dr. Shruti. If Dr. Shruti is not available, Dr. Nihanti, please. You would do as per Dr. Sanvijay, or you would have a different point of view?
Hi, Dr. Santosh. I think I would go with a different approach. I think at this juncture, I think I would prefer adding TDXD with pertuzumab because my points take would be here. She's 54-year-old. She had a good response to upfront disease with 3 year of treatment-free interval also. So currently, yes, looking into the DB09 data, I'm quite convinced and it's been practice changing and I've currently implemented in my practice also. Yeah, I would like to look into other factors which Dr. Savini has already mentioned, maybe PIK3 mutation, but even if mutation is present, I know the response wise, definitely TDXD is the to go and standard of care. But currently, I would go with
convince Dr.
TDXD.
Sanvinay.
Yeah, I
You
think
have to convince Dr. Sanvinay.
I would definitely say, see, mechanism of action is one thing which needs to be taken into account. If you look into the way ADC act and the TRAS2 PER2 combination, because TDXD any day has a better payload, a better chemotherapy drug combination, which is almost 8:1. So I think I would target it upfront and make it a point that, because even though she did mention that what are the next line of options, if you look into DB09, post progression, if PFS2 is what is very important, you can use any treatment of choice. So most of the patients have done quite better. Again, it depends upon the biology, the treatment-free interval, the performance status of the patient. So I don't think there's a dearth of any medication being added on progression also. So I think I'm quite convinced with TDXD.
Yes. Dr. Sindhu, Dr. Sanvijay chose for Cleopatra, Dr. Nihanti for DB09. So patient is in front of you. How do you decide, Dr. Sindhu?
Sir, good evening, sir. Maybe I'll go with 7 madam's order, like Cleopatra, first with DHP. The same thing, sir. We need to see the sequencing of the drugs. That is the point. So I would prefer THP first, trastuzumab and pertuzumab, then think about TDXD. Regarding the data, it is very interesting. TDXD in the first line, it is very interesting, like 40 months of PFS and all. But once if TDXD is used, we don't have things in the second line because she's 54 years old. We need to keep on giving the drugs.
So it is giving the best PFS compared to the other. Why do you think about second line when first line is giving the best outcomes?
Then the options for the second line are reduced, sir. Then we have only like tucatinib, capecitabine, and trastuzumab. That's also like the older ones are also doing it good. That's why.
You would wait for the OS data before deciding. So
Sorry,
you would
sir.
not decide on the PFS data.
Sorry,
Want to
sir.
wait for the OS to decide?
Yes, sir.
Overall
Yes, sir.
survival data.
Right. Sure. Sure. Right. Yes, sir. Yes, sir.
Yes, that is the right way of putting forward your view. Dr. Suhail,
Oh.
so you have two of the panelists choosing Cleopatra, one choosing DB09. Which way you choose? You don't have overall survival data. You have the toxicity of ILD, which is like unprecedented. It can come at any time. So what do you choose, Dr. Suhail?
So, the DB09 has clearly proven itself to be superior to the Cleopatra regime. You yourself just said that the PFS between the two, there's a difference of around 14 or 15 months. So DB09 is a clearly superior regime, and there is no doubt about it. It is superior not only in terms of PFS, it is also superior in terms of brain penetration, in terms of having a greater overall response rate. The ORR is also very good, and it is also has effect on the PIK3CA, as Dr. Nihanti had highlighted. However, the point is that TDXT plus pertuzumab is an indefinite treatment. So now I think in future we are going to have some ctDNA guided approaches where there may be a strategy of a start-stop kind of a approach where you may follow serial ctDNA, and once the ctDNA becomes close to undetectable, you may have a de-escalation kind of a strategy or a start-stop strategy where you may preserve the patients with quality of life, avoid the risk of ILD, cut down on the financial toxicity in countries like ours as well. So I think this is something that is the future.
You want DB09, that is what you use, but you have
yes,
issues regarding the duration of treatment. So that
yes,
is what
I would kill the DB09 way, and for the OS argument, I'm sure that the OS is going to be demonstrated in due course of time, and the trial investigators have already said that the follow-up effect of this drug is carrying on for PFS2 as well. So PFS2 is a reasonable surrogate for OS.
So you are convinced with the DB09, that is the way you got forward. So we'll take opinion from Dr. Lal Mohan. Sir, we have a 50-50% divide of the panelists so far. So you should help us understanding which way to go forward. Cleopatra old way or the new way of DB09?
In this scenario, HER2 positive, basically, it is better to choose best one first. So DB09 is better as compared to Cleopatra, as you have seen the trial. Like already Sahil discussed the PFS. And
yes. So you would
main aim of this trial is, or in this HER2 positive group patients, basically we want to prevent the further metastasis like brain mets. So that's why we usually use the TDX is a better CNS penetration as compared to HPV. Okay.
Right.
So that is another reason to use DB09 is better as compared to Cleopatra.
Yes. So Dr. Shruti, this case, if you treat, so which way would you treat?
And sir, good evening, sir. If given a chance, I would want to go with TDXT plus pertuzumab, which would be the standard in 2026 when we are there. I agree with my other panelists in terms that it has better CNS penetration, and we are very worried about CNS metastasis in such patients. So that is number one reason. Number two reason is that it gives a median PFS advantage of 10 months, which is very significant when we talk about metastatic patient. So I'm very convinced about that. I'm also concerned about ILD, but with a good baseline like screening testing and keeping a low threshold to get the CT, HRCT done at the onset of symptoms, or maybe just being careful about it would be a better strategy than altogether going for other regimens. So I would go, sir, Destiny Breast 9 ways.
So we have 4-2 in favor of Destiny Breast 09. So I would seek inputs from Dr. Satyajit. Dr. Satyajit, join. So no, hasn't joined. So basically, if you see the data wise, yes, DB09 has showed a fantastic improvement in PFS. Yes, OS is awaited. I partly agree with my panelists that it had issues with ILD and what do we do if it progresses. Always in oncology, the best agent first is what we have understood. The one concern is how long would we continue TDXT? Possibly, if we would have a trial, one trial is ongoing, induction kind of TDXT later de-escalate. That is the way to go forward. Possibly in real world, 6 to 8 cycles of TDXT in the DB09. Once you achieve good response, possibly come down to trastuzumab and pertuzumab. This is possibly the way in real world I would do. So with this, we'll go to the second question. The main question is, as I partially answered, 6 to 8 cycles of trastuzumab deruxtecan is what I would do. So I would start with Dr. Sanvijay. Although you have answered for Cleopatra, suppose with other change of mind, if you are given DB09, how long would you give? So after the first scan, after 4 cycles, you had complete response. So would you stop there or would you continue? Dr. Sanvijay.
Hello, sir. Sir, I have used this drug in
Yes,
a
madam.
metastatic patient once, and she had CR after 3 cycles only. So we continued for 3 more cycles,
Okay.
and then she developed grade 2 ILD, for which we need to stop the drug. So, and after
Okay.
total 6 cycles, she was in CR with serial scans for around 7 to 8 months. So I do believe that TDXT, we can think something like a treatment-free remission in CML. We think of imatinib because that is actually a good drug. I've used it only in
Right.
one patient, but still. So my strategy would be, sir, even if I continue TDXT for like 4 or 5 cycles, then I cannot give pertuzumab as a single agent drug. And
Okay.
so then I have to like either completely stop the treatment, or if the patient is hormone positive, I can just add some kind of endocrine therapy to my patient. But TDXT, as
So
soon
you
as
could
the patient is responding,
you could
and
just give trastuzumab, pertuzumab, right? You could go trastuzumab and pertuzumab after 6 cycles of TDXT. If there is CR, you could just add on trastuzumab and continue the pertuzumab. Won't that be
yeah,
a
that
right?
can be done. Yeah, that can be also done.
Yes. Dr. Shruti, how long would you give trastuzumab deruxtecan in DB09 in your real world? Dr. Nihanti, would you agree with us that 6 to 8 cycles are okay? Then you have to switch down and later switch on when again the progression happens. Are we right doing this because we do not have a data that is guiding us? But is this a right strategy, or would you give until progression? Which way do you treat, Dr. Nihanti?
I don't think it's a black and white answer. Always in oncology, I think gray is what we would prefer. If the patient is affordable, patient doesn't develop any form of toxicities, I think I would still continue TDXD because if you look into the ADC mechanism, I know it's just a hypothetical because we don't have a long-term data. So either like switch on and off mechanism, does ADC work? I'm not fully convinced with that. So if the patient has no toxicity, my treatment of choice would to continue TDXD. If she develops any form of toxicity, I either try dose reducing or go at a caping of 200 mg. In spite of that, okay, there is, again, if there's one health economic factor which comes into it, then I would definitely switch to Trastuzumab and Pertu. But again, reintroduction, I think until there is some data, I won't be convinced to change my practice, I guess.
So you would love to continue as long as
Yep.
possible if there is no financial toxicity, no ILD toxicity, and disease is in remission. So you want to go as per the textbook.
Yeah.
Yeah.
I could.
So
Yeah.
Dr. Sindhu, would you agree with Dr. Nihanti, or would you want to weigh, as Dr. Sanvijay and Dr. Shruti told, 6 to 8 cycles stopping? Dr. Sindhu? Dr. Suhail?
So, in the original DB09 study, the patients who were given the experimental approach of Enhertu plus pertuzumab, they received a median of around 20 months of this treatment, which roughly translates to around maybe 28 cycles. But I don't think that is feasible for all our patients in the real world. Because
Agreed.
in the trial, in the trial, you have the fittest of patients. In the
Yes.
real world, you would have patients who may not take that kind of a treatment, that intensive treatment very nicely. So I would definitely discuss with the patient if the response is very good about the start-stop strategy, about the experimental role of ctDNA, and about de-escalation strategies, as the doctor previously also said, that you may have a situation where you can, stop the drug and come down to HP kind of a maintenance rather than continue Enhertu cortizumab, because that is something which is very cost intensive as well as intensive with respect to side effects. The GI side effects, the nausea, the fatigue, the transaminitis, the ILD. So all of these really takes its toll on the patient. So I think yes, there has to be a finite number of cycles that one aims at.
So
And that may differ from person to
what is
person.
your finite number? So I was seeing in chat box,
6 to
somebody was
9.
telling 1 year.
6
So
to 9, 6 to 9 cycles. 6 to 9 cycles.
Yes.
I have not seen patients go beyond 10 cycles and more.
Yes, I agree. Completely agree. Possibly in the real world, 6 to 9 cycles is where we have to stop and then give them a free interval, because if it's a chemotherapy, they have a lot of nausea, a lot of side effects, unexpected ILD risk is there. Possibly after 6 to 9 cycles, give a break, trastuzumab, drug-free holiday. Maybe 1 year they'll be fine. Maybe reintroduction again. By that time, we would have data. Dr. Lal Mohan sir, so what is your viewpoint on this?
According to trial, it is actually DB90. They have continued till any toxicity developed or any disease progress. But problem here is in ADC we are using cytotoxic drugs. So that is the question. The toxicity, cumulative toxicity will be there. So that is the reason basically. How much duration should we continue? Still trials are lacking on that aspect.
Right. Okay, sir. So we
Also,
have.
sir, I had one query actually. In the DB09 paper, sir, they have clearly mentioned that those patients who developed more than equal to grade 2 ILD, no further TDXT or even no trastuzumab was given to those patients. So I don't understand why they avoided even trastuzumab in those patients.
They do not want to take even 1 ounce of risks. Suppose even one patient develops grade 4, their curves will cross again. So basically, whenever a researcher does a trial, they would be very, very safe because of unexpected toxicity or grade 2 becoming grade 4. They do not want to lose the patient. So that is the main intention behind choosing that strategy. If Dr. Satyajit has not joined, then I would have a twist to the case. Suppose everything is same. Suppose the patient was ER positive. So everything is same. The patient is ER positive, that is triple positive. Okay. Same scenario, HER2 3+, upfront this one, triple positive. In this scenario, what would we choose? We would still choose DB09, or would we choose Cleopatra followed by Pertine? I will start with Dr. Sanvijay, madam. You
sir,
already
again,
answered.
positive. Yeah. Sir, I have been following actually Cleopatra followed by Patina, and I'm very happy with that regimen, sir. So I would perhaps.
I think I'll ask Dr. Shruti. Yes, you'll be happy. You'll happy giving Cleopatra followed by Pertine. Okay. Dr. Shruti, you have answered 09.
Okay,
Dr.
sir, in
Shruti,
DB09, if I have to add endocrine therapy, I can definitely add after 6 cycles of TDXT as the trial did. But for now, sir, Cleopatra followed by Patina.
Yes. Dr. Shruti, if you have answered DB09 for hormone negative, Dr. Shruti, would you change your strategy if it's hormone positive? Dr. Shruti? Dr. Nihanti, so you have voted for DB09. So suppose if it is hormone positive, would you change your mind?
If you're actually looking into the data, especially the hazard ratios, I will feel the hormone negative subset did fare better, who had almost a 0.5 of hazard ratio. But again, HR positive subset, the hazard ratio was 0.65. So maybe in those scenarios, if the patient doesn't have brain metastasis, maybe then I would be inclined towards Patina. But if patient has brain metastasis, I think I would still go with TDXT. I think it's a more holistic approach. I would go. It's just not the hormone receptor, definitely the biology and where all the disease are present. I think accordingly, I would modify.
The same case. We don't have brain mets. The same case. We don't have brain mets in the.
Even see DB, definitely DB09, even in HR positive, in spite of 0.65 hazard ratio was convincing. I think I would be inclined to patina. I think that's what I would do.
So what I would do is, suppose it was hormone positive, I would have gone the Cleopatra followed by Pertain way, because the Cleopatra trial hormone positives did not receive any ounce of endocrine therapy of the induction phase. So that is one of the biggest flaw of the Cleopatra, even though it was one of the landmark trial. Suppose they would have added, it would have been much more beneficial. That is what I would do in hormone positives. If there are no brain metastasis, in this case, I would give a Cleopatra kind of strategy followed by Pertain.
Yeah,
Dr. Sindhu, if it was hormone positive, you already chose Cleopatra, so you would obviously choose Cleopatra. Dr. Suhail, so would you change from DB09 to Cleopatra if it is hormone positive?
Very interesting question and very tempting. The Patina strategy showed a PFS of 44 months, if I'm not wrong. So that's really exciting. And DB09 is showing a median PFS of around 40 months, 41 months, or thereabouts. More importantly, the Patina strategy allows me to give the patient an easier treatment. The patient can just come once in 3 weeks for a good hospital visit and maybe take a subcutaneous Fesco kind of a combination and continue to take oral pills at home with no risk of any major side effects like ILD or the side effects of TDXT that we were talking about. So yes, I agree that in hormone positive patients, especially as you said, without brain metastasis, I would shift. I would go the Cleopatra followed by Patina way.
Yes. Dr. Lalmohan.
Yes, rightly, Sohail has already told. Basically, if it is hormone positive, we basically go with the Cleopatra followed by Patina, which has also shown the same PFS as like DB09. In continuous TDXD, you will get a cumulative toxicity. So that is problem. So Patina will be a better choice. That is, will add the endocrine therapy with palbociclib with HP.
Right. So I think my panelists have given very expert inputs. So to put in straight, suppose if it's hormone positive without brain mets, let us go in a Cleopatra way and possibly shift to Pertain. So Pertain is one trial. It's like it has given life to palbociclib. So in many of the trials in advanced hormone positive where Abima and ribociclib showed overall survival, this is where palbociclib again regained. It has risen from the death. That is what I view like after the Pertain trial, where it was dead ball before a lot of generics came. So I think that's a very good opportunity for Indian patients. That is, give Cleopatra followed by Pertain. Suppose
so
if it is
two trials have actually resurrected palbociclib. One is Patina and the other is the Inavo 120. If you use for upfront, then the inavolisib and palbociclib fulvestrant combination that also has a overall survival benefit.
Yes, correct. So suppose if it is hormone negative, we have two strategies, either give DB09 or the alternate or the practical approach would be give Cleopatra. After Cleopatra, you add the TDM1. We have very good data with HER2 climb as one of our panelists, Dr. Sanvijay told. So possibly this is the way to move forward. So let's switch gear. So this is a 61-year-old woman. Hormone receptor positive. On IHC for HER2, it is 1+, so HER2 low. Metastatic breast cancer. She has progressed on 2 lines of endocrine therapy with a CDK4/6. So fulvestrant was the second line of treatment she received. So you have done the mutation test, both ESR1 and PIK3 are negative. So this is the scenario. 2 lines of endocrine therapy, HER2 low. So how do we choose? Should we do TROP testing, Dr. Sanvijay? Would you do using any ADC TROP testing, or it's okay even without that we can decide on treatment?
Sir, generally without that also we can choose sacituzumab govitecan. But in this lady, sir, I would go with trastuzumab deruxtecan first of all, sir.
Okay. Dr. Shruti, TROP testing and which treatment would you choose? So Dr. Nihanti?
In my clinical practice, currently I'm not doing it, but maybe theoretically I would agree to it. But definitely, irrespective of it, treatment won't change. I would still be inclined to TDXD only.
So we are getting a lot of newer agents in the form of endocrine therapy, possible evenolizumab or
Yeah.
LSS or newer generation PIK3 inhibitors or whatever. It's also PIK3 was negative.
Yeah,
Should we
ESR1 is negative, so I don't think LSS strand is can be used in this scenario. Maybe if ESR1 was positive or AKT pathway was, anything was significantly mutated, I would definitely change my treatment option. Definitely at this juncture, first I would get an NGS, look into the underlying any possible mutation present, accordingly target the mutation. If no target is available, I think TDXD is the way to go for me.
Right. I'll move to the next slide. So 61-year-old lady, TNBC, upfront metastatic, PDL1 18%. Dr. Sanvijay, so how do you choose the initial treatment?
Sir, clearly, sir, Keynote 355, pembrolizumab with paclitaxel or maybe nab-paclitaxel or even gem-carbo with pembrolizumab.
So won't you introduce ADC upfront? We are having emerging data.
Yes, sir, we do have the data of combination of pembro with sacituzumab govitecan.
So
But
it would
sir,
be
right now, more,
you're always choosing the previous molecules. Cleopatra also you choose previous. Why aren't you choosing the latest happening?
no, sir, I guess I have experience with Keynote 355 and
You
it's a
would
good.
Conventional, tried and tested. So that's what you want to choose.
No, sir, not like that. I mean, like sacituzumab govitecan, sir, for many reasons, sir. First of all, it is also not an easy drug to be given to the patient. Like I have given it to one patient who has progressed on 2 lines in metastatic TNBC, and the patient had a lot of diarrhea and was admitted twice or thrice with neutropenia. Plus, access to the drug is an issue. So, sir, if I have something which is more easy to be given and relatively less financially toxic also, then I can say it is not inferior, sir. I mean,
Okay. So you want to go tried and tested way. You don't want to experiment new things. Okay. Taken. Point well taken. Dr. Nihanti. So you always choose the latest molecule. So this is the patient in front of you. So you would go the ASCENT-4 way, or as Dr. Sanvijay has told, you want to go with the tried and tested 355.
CSN data is quite convincing, but I've not used it yet. I think I would go. I think sacituzumab govitecan. I think because of neutropenia and a lot of complication, because this patient, I would go with the pembrolizumab and a backbone chemotherapy.
Okay. So Dr. Sindhu?
Yes, sir. Same way, sir. I would prefer, like rather than sacituzumab, I would prefer chemotherapy plus, according to the Keynote trial, sir, pembrolizumab.
Dr. Suhail sir, all my panelists want to give the previous regimen. So you want to go the same way, or you want to try the best drug that is available, SG plus pembrolizumab, ASCENT-4?
So definitely, I would say that that is the way forward, and that is going to be the newer standard. I agree with my panelists when they say that they've not used it too often, and also the fact that SG is not an easy drug. But if you don't use it in a fit patient who is going to be able to tolerate it better, then we'll never have the experience of using it either. So yes, for a patient who is financially affordable and fit otherwise, I would definitely use SG plus Pembro upfront. Not only it offers a median PFS of a numerical advantage of 3.5 to 4 months, but it also has a deeper depth of response. It also gives me a greater overall response rate. So yes, for a fit patient who is able to take the drug, I would go for SG plus Pembro. If not, then I agree that in the real world, we all end up doing chemo plus Pembro more often than not.
Dr. Sanvijay, Dr. Suhail sir is telling that the data is very strong, depth, the prolonged and all the things. So will that convince you from changing your protocol? Because the data is really appealing, because in TNBCs, hit hard and early because they did not give chance
Yes.
in the second line. So in HER2s, I understand we have an option, but in triple negatives, we do not have a second option. So we have to hit hard and early. So would you change your matlab, line of thought process after listening to Dr. Suhail? Or would you
Yes,
stick
sir.
on
I will
to the same?
definitely give it a thought after listening to Suhail, sir.
Dr. Nihanti,
So,
would you
so
also
just
change?
see, Dr. Santosh, I mean, if you would compare the response rate, then the duration of response with SG plus Pembro is to the tune of 9
Definitely.
months,
Yes,
and
sir.
SG plus Pembro is almost double, 16.5 months. So, and the recent updated ASCO 2026, they showed that the benefit continues even for the patients who cross over.
Yeah.
So even after, it is not as if you give SG the early benefit is not simply because of the receiving SG later. So if you cross over later, also then the patients continue to derive benefit. So I would say yes, put your best foot forward, because in metastatic TNBC you have very few options, you know.
Yes.
And chemotherapy is like something that we've all been burnt our fingers with chemotherapy, different toxicities and so on. I agree, SG is also not a very, very safe drug for an elderly, frail patient. But then put your best foot forward first up.
Dr. Nihanti, would you agree now? Or you would
No.
stick on to the same thing?
No, I totally agree. The ASCENT-4 data, if you look in, definitely there is a statistical and numerical benefit. But in clinical scenario, how much can we implement on our patient is the question which I would look into. Because most of our patients, if they don't turn up with a very good performance status, and SG, definitely the toxicity is quite high. Even though numbers are quite significant, the overall responses is high, the durable responses are there. But for how long am I going to give is the question which I would ask in my clinical practice. Because
So
with
you would
Pembro,
discuss with the patient the options, toxicities, and you would have
definitely.
a combined discussion.
I
Okay.
think the data is quite significant. There is no question about the data at all, the durable responses, everything. But in clinical practice, how much can we integrate and implement is what I would look into it.
Dr. Sindhu, would you change or you would continue with the same?
I would continue with the same, sir.
Dr. Lal Mohan?
Yes, in metastatic TNBC, basically before we go for treatment, we will do the germline BRCA test to see whether it is there. And as we already know, it is given the sacubitril govitecan with Pembro is the first line indication. And in TNBC patients, apart from PD-L1, other is the TROP2 receptor that we want to look for. And TROP2, if you see, it is more than 90% of tumor cell it is expressed. So TROP2 biomarker is not needed.
Yes, yes.
Before treatment. So because of its mechanism of action, of its bystander effect, so better to go for, I think, ASCENT-04, that is SG with Pembro.
Yes. So I think all my panelists have put the good point of view. Dr. Satyajit, is he joined? Or Dr. Shruti is available now? If not, I will conclude this case. Possibly, yes, ASCENT-4, the data is very promising. We have to discuss with our patient with more availability of the drug in the future. Yes, this is the right way to go forward. But yes, we have to control the toxicity. We are all well versed managing neutropenias and all. We have seen the docetaxel. If somebody practices hemato-oncology also, we know how to manage neutropenia. I think in a TNBC, we have to go ahead and go all guns blazing, giving the best agent. Suppose the patient has a PD-L1 of 10%. How do we go? Dr. Sanvijay, if the PD-L1 is 5%, so how do you decide? Same patient, everything is same. PD-L1 is 5%.
So then we do have the evidence of using sacituzumab govitecan upfront, sir.
So
So
we
we
have
can use that.
datopotamab also.
Yes, sir.
So how do you choose these two?
Sir, not aware, sir.
Okay.
Regarding
So,
datopotamab, sir, I'm not
Nihanti,
sure.
suppose if the PD-L1 is less than 10%, which ADC would you use? Dr. Nihanti?
Yes. I'm so sorry. Please, can you repeat the question?
Suppose the same patient, PD-L1 is 5%. So what treatment would you give?
PD-L1 is 5%. Definitely, I would either incline to one of the ADCs, I think, either sacituzumab or dapirolizumab, whichever, but I have not used either of them in my clinical scenario. So data-wise, yes. Theoretically, yes. But practically, I have no experience about that.
Okay. Dr. Suhail?
So if the PD-L1 score is less than 10, then your pembro goes out as per the data. And then in that case, I'm going to be looking at the HER2 expression, whether it is 1+ or 2+. If it is HER2 low, or gives me the option of adding TDXV, bringing in my
HER2 low,
other
you want to give
ADC.
upfront TDXT in HER2 low?
So you have Destiny Breast 06, where you have TDXT coming to the first line.
It is hormone positive, right? Hormone positive post endocrine. So in HER2 low upfront in a TNBC kind of setup, I think we don't have a data of upfront use of trastuzumab.
Not upfront. Maybe sequencing is later. Maybe in that case, I would look at BRCA also. If the BRCA gives me some hope for using PARP inhibitors, then my options for PARP inhibitors will open up. Otherwise, it's the conventional chemotherapy.
Okay. Dr. Lal Mohan?
Yes, in PD-L1 less than 10, basically we use single agent either SASI or datopotamab deruxtecan. If we see the TROPION-Breast02 trial, the data one, I think that data is mature, and so data is preferred as compared to SASI in this scenario.
Right. So I think we have two drugs in this scenario, sacituzumab and datopotamab. More or less both show equivalent PFS because of the inherent trial design. One showed OS, other did not show because it allowed crossover. But both molecules, according to me, are essentially same. Possibly we should choose based on the toxicity profile, where the administration of SG is weekly once, whereas datopotamab once in 3 weekly. So based on the case-to-case scenario, based on the toxicity profile and the ease of administration, we should choose one of the above agents. So so this one I'll skip. Generally, there is a intense discussion that suppose a patient runs on an ADC. Can I request IOIO? How much time do I have? Or we have overseeded the time, or based on that I'll conclude?
No, you have 15 minutes. There's one talk got cancelled, na? So I think we can go till 8. So I think till you have 15 minutes or maybe.
Okay, right. So generally, suppose if a patient has been exposed to trastuzumab deruxtecan, how do we choose the other next line? So there is an intense debate of whether it is the target or it is the payload. So there is conflicting data to change the target, to change the payload, but we do not have a lot of options. We have TROP2, HER2, but most of the payload is topoisomerase inhibitor. So there is interesting data where in a DAISY trial, 50-65% of patients have downregulation of receptor for HER2. So possibly post trastuzumab deruxtecan, if there is downregulation or ERBB binding, possibly TDM1 and all will not work. So possibly we should shift to TROP2. So that is one signal that we are getting. Suppose if there is TOP1 mutation or SLX4, this is the case where our payload, that is topoisomerase inhibitors, doesn't work. So in this scenario, possibly TDM1 might work because it is a taxane. So this is some silent signaling. So based on that, it will give us an idea to decide how do we choose the subsequent second line. So I would put forward a simple straight question. We have a fantastic data with 2 trials with trastuzumab deruxtecan. We have the neoadjuvant and the adjuvant trial, DB05 and DB11. So I would start with Dr. Sanvijay. So which strategy would you choose in a patient of HER2 early stage? So now we have discussed the latest or the advanced stage. We shift gear to the early stage, HER2 positive, node positive disease. 3 nodes are positive. So neoadjuvant versus adjuvant TDXT. Dr. Sanvijay.
Sir, after DB03, sir, I am very much impressed with this DB05 data. Because sir,
Yes.
if we compare this TDXT with TDM1 in the patients who had residual disease after neoadjuvant therapy, so sir, this trial did take patients who were actually inoperable at presentation, and like most of the patients received a dual anti-HER2 agent. Like if we compare it with a Catherine trial, which had shown benefit previously, there, sir, hardly 20 to 30% patients received dual anti-HER2 agents. So I guess more aggressive patients were selected in DB05 trial, and then also it did show a 10% IDFS benefit, which is to me very impressive, sir. So if my patient can afford, I am definitely up for 14 cycles of adjuvant TDXT.
So
Yeah.
PTXT is a fantastic data. I think the points very well put forward. One
Yes, sir.
important lacune with Catherine TDM1 is intracranial protection was very, very worse. A lot of patients
Yes, sir.
progressed in future with brain metastasis. That is
Yes,
covered
sir.
with TDXT. So
Yes, sir.
agreed, DB05 is the standard of care. What
Yes.
about neoadjuvant TDXT? Are you ready for neoadjuvant TDXT?
Sir, I would like to still wait for the data to get mature for new adjuvant TDXT, sir.
Okay. Dr. Shruti? DB05 or DB11 way? Dr. Nihanti?
I think I'm still I'm quite convinced with the adjuvant way. I think that's the way to go about it, because if you're just looking on a cross comparison basis on hazard ratio, most of the points Dr. Savine has already quoted, I think that's definitely holds a upper hand compared to the neoadjuvant. But if you're getting into the neoadjuvant data currently, because of the updated one, even that seems convincing. But yeah, I would still wait for further data to be mature, maybe for a practice changing. Adjuvant, yes. Neoadjuvant, I would still want to look for the data per se.
Dr. Sindhu? So, Dr. Suhail?
So the data looks promising. I've not used neoadjuvant TDXT, but I would be very skeptical of the data till it becomes mature, especially because for patients, what do I do for patients who have residual disease after surgery, even with neoadjuvant TDXT? So on one hand, I'm saying that adjuvant TDXT is better than adjuvant TDM1 for patients who have residual pathological disease after the TCHP kind of an induction. So there, the DB05 clearly said that TDXD is better than TDM1. Now, if I bring TDXD in the neoadjuvant sphere, the pathological complete response rates in DB11 are to the tune of 65, 66%, which is very similar to what we get in TCHP as well, around 64%. So when these patients end up having surgery and have residual disease, do I take them again to TDM1, which as it is has been proven to be inferior to TDXT, at the expense of the fact that maybe I'm giving the patients less financial toxicity and less ILD by giving only 4 cycles of TDXD in the NECT sphere. So I have my doubts and my reservations for the new adjuvant TDXD. But yes, convinced about adjuvant TDXD being the game changer, because the Kaplan-Meier curves start separating from the very beginning and they continue to widen out as the time progresses. So adjuvant TDXD for me is a yes for now. For TDXD as a new adjuvant strategy, I would like to still hold my horses.
Dr. Lal Mohan, sir?
Yes, in adjuvant TDSD, we are agreed all that it is superior as compared to the TDM1. But in neoadjuvant, trial design is good. Basically, here it is designed to reduce the anthracycline toxicity. That's why TDSD was given on DB11. And also path share is quite impressive, that is 67% nearly. And if you see the RCB 0 and 1 to group patients, that is nearly 80% of patients. So more of the patients are to the residual 0 and 1. So that is what long-term data is, we are waiting that EFS data. So that will give us more about the DB11.
So I think very good points told by all of my expert panelists. So one point I would put forward is whenever we deal with a metastatic disease, it's a palliative intent. But whenever we come to the neoadjuvant and adjuvant scenario, we are going with a curative intent. So we do not want lot of treatment-related side effects. Both in the DB5 and DB11, we have seen grade 5 side effects also. Suppose if I start a neoadjuvant strategy, I would give all 100 patients the TDXT. So the risk of getting toxicity is higher. Suppose if I choose an adjuvant strategy, I would filter out the most highest risk of patients who would require it. Possibly, if you ask me, or my point of view is an adjuvant strategy of choosing the most high-risk patients who tend to do poor without TDXT is the right strategy rather than giving TDXT to everyone neoadjuvant. That is the view I take forward. So possibly adjuvant is the way to go forward. Neoadjuvant, I am not agreeing or subjecting a lot of people to this unexpected and untimely side effect. We don't know who would develop this ILD in spite of stringent monitoring. In the clinical trial, we had grade 5 toxicities. In real world, we know with our follow-up patients, sometimes very closely following patient also we would miss. So that is the view that I would put on when deciding neoadjuvant versus adjuvant strategy. At the same time, there was a third arm in the neoadjuvant where the single agent arm, I think they have stopped recruiting and all. So that also would give me a doubt that possibly adjuvant way is the way to go forward. We would be choosing the most high risk of patients and also give them neuroprotection over TDN1. So if I give neoadjuvant, I'm risking more patients, more risk of lung toxicity. And suppose there is residual disease after this one, how do I go ahead? Should I add TDM1? Should I add tucatinib to it? Nobody knows the answer. So if you ask me, it's the adjuvant way. It is a game changer in a lot of patients who do not have it. With this, I think I would come to the last part of discussion with this emerging agents in the form of a lot of ADCs. It's the time to say Tata or bye-bye to TDM1, or do we have any role? Dr. Sanvijay? Or it's a gone molecule?
Sir, for those who cannot afford TDXT, obviously TDM has a place both in adjuvant setting as well as in the metastatic setting. Although, sir, every time we talk about the ILD toxicities of TDXT, the GI toxicities, but I have also experienced that even TDM1 can get very toxic in terms of like hepatotoxicity and thrombocytopenia. Like 2 of my patients never recovered from their thrombocytopenia, like for a long period of time. So they were off treatment in the adjuvant setting for 3 months. So like such kind of toxicities do happen, and we don't know who are going to be those patients. But I guess in adjuvant setting and metastatic setting, I am convinced that TDXT definitely is superior than TDM1, sir.
Yes. Dr. Nihanti, so it's the time to say bye-bye to TDM1?
See, if you're looking in the data, definitely TDXD and all ADCs are the way to go in the current future. But again, if you're looking into the economics per se, patients are not affordable. I think in those other patients, I would still prefer TDM1 in my clinical practice. So we can't say that, okay, the drug has been excluded. Looking into the data wise, definitely ADCs way to go. But looking into the practical aspect, I think TDM1 still we all use in our practice, either of the way, Catherine or Emilia, and in some or the other form, we will definitely be using it.
Dr. Sindhu? Dr. Suhail?
So I don't think that TDM1 is a molecule that we should say bye-bye to. I think it still has a lot of promise, especially in a country like ours. Secondly, what do you do for someone, let us say, who has a locally advanced breast cancer and after induction NACT with TCHP ends up having a microscopic focus of disease in the node, has PCR in the breast, but maybe N1 microscopic. No, technically, this is not a pathological complete response, but I think using TDXT for this kind of a patient would perhaps be an overkill. So I think I would still weigh something or the other in favor of TDM1 and maybe give TDXT the option of being utilized in the second line as and when the situation demands. So yes, judiciously we have to understand which situation demands TDM1, because these are the kind of patients where we have been historically discussing whether we can even continue with the H+P backbone rather than go to TDM1. And many of the times people do reasonably well with even HP for microscopic residual disease in the breast or the nodes. So for these patients, now we are giving TDM1 as per data. But TDXT would be a slightly overkill for these patients. So I would just wait and give TDM1 for these patients.
Dr. Lal Mohan, sir.
Yes, after TDXT's role as ADC, TDM1's role is coming in a later line. Basically, adjuvant, it has no place. But in metastatic setting, you can consider it on second line if patients cannot afford TDXT. That is the reason. Basically, that is the cause why TDM's role is now in a later line. It is coming.
So in the real world, in Indian scenario, with availability of the generic
Yeah,
TD,
Indian scenario, we should keep it because we cannot give TDXT to everyone. So
with careful
we
monitoring of
can.
liver functions and thrombocytopenia, I think that is the way we have to. There is an issue with the linker with the TDM1. It causes the sinusoidal occlusion and the hepatotoxicity and the portal hypertension and causing thrombocytopenia. Yes, there is issue with this, but I think in Indian scenario, this is the way to go forward. I think we had fantastic discussions. Thank you all my panelists. I think you were very, very informative in terms of deciphering the data, the way to go forward. I really learned a lot from you all. I think ADCs are here to stay, and we are able to understand which ADC is better. How do we use ADC after ADC? How do we change the payload? What is the target? These are the various things we have data to be awaited of. So, but both in triple negative, hormone positive, and HER2, we have the ADCs. From the advanced setting, they have moved very early into the neoadjuvant and the first line in there. So this is what I would conclude. I would hand over the thing to the organizers. Thank you, Dr. Uma Dangi, madam, for inviting me and having me as the moderator. It was fantastic discussion. Thank you once again, all the panelists and the organizers and Dr. Uma Dangi and IAIO. Thank you. I would conclude with this.
Thank you, Dr. Santosh and all the panelists. It was really a very, very wonderful discussion and a really informative session. I think somebody also mentioned that a lot of information, the session has been quite informative. So thank you all. And I really was happy to be a part of this program. So hopefully we'll continue to see you in our future endeavors. So thank you. Thank you, Dr. Prabhat, for that excellent talk as well. So with that, I will conclude. Any final remarks from you?
Yes, ma'am.
So
As we come
anything
to
else
the
you
end
want
of
to add?
today's enriching session. Yes, ma'am.
I think I have some network.
Okay, as we come to the end of today's enriching academic session, I would like to express my sincere gratitude to our program director for her outstanding leadership and guidance. Our heartfelt thanks to all our esteemed faculty members. Thank you for sharing your expertise and valuable clinical perspectives with all of us. We also thank all our participants for your active participation and continued support of IAIO Academic Initiatives. On behalf of the International Association for Integrated Oncology, IAIO, thank you for joining us today. Have a wonderful evening. Stay safe. Thank you, everyone. Good night.
Thanks. Bye.
Bye.
Thank you.